Hi, good evening, everyone. I'm Mandeep and I belong to Wipro G. I welcome you all to this. I welcome you all to the panel discussion on intrapartum monitoring.
Good evening and thank you so much. I would like to thank GE for organizing this wonderful panel discussion on a very important topic of intrapartum fetal monitoring. We have with us some of the most esteemed doctors and who are the most knowledgeable in this field. Uh, Firstly, I would like to invite Dr. Archana Baser, ma'am, and Dr. Chinmay Omarji. Dr. Archana Baser needs no introduction. We all know her. She is our FOGSI Vice President. And Dr. Chinmay Omarji again needs no introduction. He is one of the top fetal medicine consultants and obstetricians in Pune. I would like to invite Dr. Archana Baser further to tell us regarding today's session and to continue to introduce the panel further. Ma'am, over to you.
Good evening, everyone. At the outset, let me welcome all the panelists and all the faculty members here, Dr. Suchitra Pandit. They have all agreed just on one WhatsApp message. So, thank you, Suchitra, for joining. My dear friend, Dr. Meeta, Dr. Vandana, Dr. Iyer, Dr. Gupta, Dr. Chanchal. I think it was initiative of Dr. Chinmay Umarji. He called me up, madam, we want to do one program on intrapartum fetal monitoring. I said, let's speak to Dr. Sarita Bhalerao. She is chairperson of AICC RCOG India West Zone representative, and she happily agreed that yes, it is a very important topic and we should be, doing it on from West Zone. So thank you, Sarita, for giving us this platform, and G for really, bringing up good program together. So we have a really program where we have all the esteemed panelists. They are all expert in this field, and we will be introducing one by one to them. And we are having a panel which will be about 45 minutes to 1 hour, and then we have a very good lecture lined up for on the guidelines of continuous topography monitoring by Professor Campus. So, can I have the CV of Dr. Meeta Nakre here? Or, I really don't need a CV of Dr. Meeta. Dr. Meeta Nakre is FRCOG. She is head of the department, Maharashtra Medical Foundation, Pune, and consultant in charge, Ratna Women's Clinic. I know Dr. Meeta from I think from 2005. It's 2005. I know her, and she's a very, very, meticulous person. She was used to run MRCOG courses, and we had many memories together. So, and we will be really happy to have her inputs on this panel discussion. So welcome, Meeta, to this panel, and thank you for agreeing to be part of this panel discussion. And may I have the CV of Dr. Vandana Bansal now? Vandana Bansal, again, is a consultant at Surya Hospital, and she is a very dedicated fetal medicine person, a very nice, down-to-earth person, very knowledgeable. She is chairperson Fetal Medicine Committee, EMOX, National Coordinator Imaging Science Committee, FOXY, and she is member Managing Committee, MOGS. And welcome, Vandana. And we'll be really, I think delegates will be delighted to hear your inputs in this panel. So over to Chinmay to introduce rest of the panelists.
It's my pleasure and privilege to introduce Dr. Chanchal. She is a lead consultant in fetal medicine at Trenbo Apollo, a thorough academician focused on mothers, babies, and their well-being. So thanks, Dr. Chanchal, to be here. Dr. Siddesh, my good friend, he's assistant professor from Cooper, Mumbai. He's a private practitioner in Mumbai, and of course member of multiple committees and managing committees, received multiple awards. and our own very own Dr. Mukesh Gupta. He also is a consultant in Mumbai. He is president of an organization of Ops and Gynae consultants there, and it's our pleasure and privilege to have Dr. Gupta here. Over to you, ma'am, about the aims and objectives.
I think it might be good to, just since we have Dr. Suchitra Pandit here and she's chairing the session, Dr. Suchitra's CV also. So I think, what can I say about Suchitra? Suchitra is a teacher's of teacher. She is a brilliant person. She has been past president of FOXY. She's been chairperson AICC RCOG. She is a president ISOPAP, and I think she has many publications. And she has conceptualized FOXY Youth Mela for empowering youth and done more than 300 continuing activities. She has been awarded 35 orations and several prizes. So, I mean, it is a really proud privilege to have Suchitra with us on this program today. So, thank you, Suchitra, for being here. I mean, aims and objectives of today's panelists, to change day-to-day clinical practice in accordance with current guidelines and standard of care. And by the end of this presentation, the users will understand fetal physiology, individualization of intrapartum care, an overview of how to interpret CTG, newer modalities, and documentation. It is very important because we all know that CTG is important and it is used at many a times as a weapon to to perform a C-section, and at times it is used as a means just to say, well, many a times I have observed that women are being put on CTG and just okay, things are going, you're just hearing the heart sounds, but it's very important to interpret it very well so that actions can be taken in time. So next slide, please. I mean, there's why we are really worried is because C-section rate in countries have gone up, and the difference in C-section delivery from NFHS 1 to NFHS 4 shows that 7 states have C-section rate that is more than 30%, and 8 states has C-section rate in between 10% and 20%, and 9 states less than 10%. So basically, there is a problem of increasing cesarean section rate. So it's very important that we really use whatever tools we have judiciously. And there has been an increase in demand from patient for safe vaginal birth. So over to you, Chinmay, to take you through a couple of next slides.
As ma'am nicely elaborated, on one side there is increase in cesareans, on the other side patients want vaginal births, and in between we are worried about the safety of the baby as well as the mother. So we want to balance and reduce our unindicated cesareans, at the same time save more babies and avoid hypoxias. There are only a few tools which are available with us: electronic fetal monitoring, FPS, STAN, intermittent auscultation. And use one tool, you increase the cesareans; use the other tool, you may lose a baby. So how do you balance this? Why don't we elaborate this with another case of ma'ams? So here is a primigravida, young, 39 weeks, leaking since 14 hours, and that is the reason why she was induced vaginally. The expected fetal weight was reasonable, and CTG at 8 hours was like this. So Dr. Siddesh, would you like to interpret the CTG for us?
The CTG, the contractions are pretty okay. Is getting good amount of contractions, as shown on the toco down. The beat to beat variability also is fine. It is not gone yet, but then there are decelerations, intermittent decelerations that can be seen. So I am not very happy with the CTG. I would probably keep a close watch on this patient and inform the relatives that things are not hunky dory at the moment.
Meeta ma'am, we did a vaginal examination. She is still not in active phase of labor. is 3 centimeter dilated, station is still high. What would you like to do?
See, let's get an overall clinical picture. Most women at 38 weeks of gestation with a premature rupture of membranes, more than 60% would have gone into labor in the first 24 hours. But this lady was induced at 14 hours for some reason. Overall, if the mother is comfortable, she's well hydrated, she's getting good, strong contractions. We are not only going to look at the CTG, we're going to look at the overall pattern. And one thing which strikes me is that the station is still quite high. Already the baby is showing a little signs of distress. Either to distress the baby and then take some action, or start talking to the predators. We have done what we can do, but at the moment, things are not going our way. So start planning for a C-section.
Yes, ma'am. So if we decided to do intrauterine resuscitation, Dr. Gupta, how would you like to do it?
So I think Dr. Meeta has given the direction already. We should be starting to prepare. I think there's hardly a role in this case, although if you're just asking. So when we are doing evaluation and we are thinking about the role of oxygen, left lateral, and head low, I don't think that there is much role to discuss about it. And what is most important in this case is having close watch on the fetal monitoring. And if required, we need to take action at the right time. Delay in action is going to be more detrimental rather than trying experimental things. Over to you.
Right. Thank you, Dr. Gupta. So, Dr. Chanchal, we decided to do the intrauterine resuscitation with intravenous fluids, positioning, and CTG was like this. Your comments, please. Can somebody else take the question for Dr. Chanchal? So I think Dr. Meeta has already given us the direction, and so the plan would be cesarean, which was executed. A healthy 3.1 kilo baby was delivered. Cord blood pHs were absolutely normal.
Can I add on to this?
Yes, ma'am.
We need to get into controversies. If you go back to the first CTG, the first one which we started with, it has got good variability. There are accelerations. All the decelerations are early decelerations. So if you go by the guidelines, all of them are decelerations. So I would actually not be so much worried. In the new guideline, early deceleration with good variability, with good accelerations are category which is normal, not even suspicious. And even in the second CTG that we have, we get to the second one. Again, here the contractions have come down, and again the decelerations are peaking with the peak of the contractions, all of them. And you can see one deceleration also. So I would again say stability in the deceleration is good. So if you put them into those parameters, it again doesn't fall into a pathological CTG. And I would still want to wait on because the LICO was clear and she's 3 centimeter and contractions are good, and I would follow it up. So let us go to controversy.
Thank you. Thank you so much for bringing this up, ma'am. And that is what the baby reflected. Baby was absolutely healthy. Probably the cesarean at that moment was not indicated. Maybe she would have received a cesarean later for some other reason. But that CTG, as ma'am rightly suggested, did not probably warrant a cesarean. So thank you for that. And that really raises the question whether the decision was appropriate and how do we make the right decision. And then we become the path in front of Bhagwan Sri Krishna and get confused on how to monitor the baby. So Dr. Chanchal, if you are back again, can you tell us more about monitoring of the labor? For some reason, I think Dr. Chanchal is not here. So Dr. Meeta, would you like to take this question?
Sure. I mean, this lady is relatively, for the mother, make sure that she's comfortable, well hydrated, has enough of pain relief, making sure her positioning is good, making sure that her communication is good. You've shown a very nice Muse chart, which is telling us all the parameters: pulse, blood pressure, temperature, respiratory rate, number of contractions, if she's in need of any pain relief.
But we have to remember that if there is who is taking it, how often is it taken is also important. This is a lady with premature rupture of membranes. So making sure that even somebody is noticing if the vaginal discharge, if her temperature is measured every 4 hours, her pulse blood pressure every 4 hours, if she is complaining of any other unusual symptoms of sudden pain or sudden gush of blood, all these parameters to be monitored, and most importantly is ask for help, or if you do not understand it, get the next senior person to come and view it with you. So that's a very nice chart you have put up. And Chinmay, do you want to take us through your chart?
Sure, ma'am. So, as you very rightly pointed out, this is called a MU chart, maternal early warning system. And we have realized that since we started implementing this chart, our calls have become much more systematic and our response has become much more methodical. So, registrar on the ward knows when to respond and how to respond. They sometimes even change the limits for, say, a mother with a baseline pulse of 110. They'll change the color code for her on their own. And they take appropriate actions. So that is very, very important. And we as seniors sitting at home sometimes are really worried about well-being of our patient. I think MU charts help us take this away. So I would recommend all the audience to get those. They're freely available across Google. So just get them for yourself and start using them. What do you think, Archana, ma'am?
I think it is very important to monitor labor carefully. I agree with Vandana, because on one side we are trying to reduce the C-section rate, and we are performing a cesarean section when there's no real fetal indication for doing, because you have to give. I am preparing for, I'm just reading about with my daughter. She's preparing for exam. That how really you have to be watchful, and watchful expectancy with good monitoring really should be done, and everything has to be documented. The most important thing is you document it. And these partograms, and these days we have very many helps available online. Engines are available and you can really make use of it. But the only thing, what was used to be told by my professor, that you have to be patient. So we should not get impatient. That's what is the problem which we are facing today, because we have smartphones. So we start becoming very impatient soon. So, but labor takes its time. That has to be understood.
Thank you so much for your inputs, ma'am. Dr. Gupta, would you like to tell us more about monitoring of the labor?
So before we go ahead, let us understand the importance of the Muse chart. And we need to understand that when we are creating any module for action and escalation, or we call it risk stratification, the basic fundamental aspect is appropriate engagement of the consultants and the whole team, number one. Number two, I also want that just by downloading and sticking it on the labor room is not going to help us. It has to be done in the form of mock drills where we do independent sessions to do that. I would be really happy if, Chinmay, you could really run through the checklist of Muse. It would be really great. So I'm just going through another aspect. And remember that Muse is not one-off. It is an intermittent assessment where you have to keep on doing it at a regular interval. And if we don't do that, it is not going to help us in clinical judgment. So when Dr. Vandana brought up very interestingly the reading of the graph, it is very obvious that we need to look at the clinical situation and the objectivity which has been produced by an objective nature of a printout or a graph. So the amalgamation of the information which is in print with that, it becomes the crux of our monitoring. And when we are talking about monitoring of the labor. So when you're talking about monitoring of the labor, we need to at this point decide that we have to go through the detailed history and the detailed clinical examination of the background. And having that, we need to do the risk stratification and decide what kind of monitoring this lady requires. Whether she comes in the category of high risk or low risk. And depending on that, we can create the whole chart. So I'm not going to go through this August audience about the baselines, about monitoring of the contractions and other things. But one thing I will say before we decide on the risk stratification of low risk and high risk is intelligent fetal heart rate monitoring. When I'm saying intelligent fetal heart rate monitoring, we need to understand that whether you choose to do intermittent or whether we choose to do continuous electronic fetal, we'll come to that as we go ahead. But we need to decide that even when we do it as an intermittent, we need to know that we have to seek for a whole minute, because we do not want to multiply the risk of error when we do it for 15 seconds multiply 4. Number two, it has to be done post contractions to identify the early decelerations clinically. And number three, I would say that it should be done for at least 3 contractions or 10 minutes, whichever earlier you want to think about, but it should be done in a complete in toto. And we need to follow frequency depending on the situation, whether we want to do it every 15 minutes or 30 minutes or whatever protocol. And when we are in second stage, maybe more early, every 5 minutes or after every contraction. I think this is the way I would put. I'm not going on the maternal aspect of monitoring, the fetal aspect of monitoring, and the labor monitoring in itself. So I'm not talking about that, because that is something all of us know. But one last statement I would like to make here is that when we are knowing that we need to monitor the patient, every patient in labor, we need to divide it into 2 components. One is the technical skills that our team has, and another is the non-technical skills, whether they're trained to respond effectively and in an appropriate way when the call for action is needed. Over to you, Chinmay.
Yeah, so we are going to anyways discuss about monitoring of the baby in a minute. So, Dr. Bansal, would you like to tell us more about our own Foxy's Manyata program and how does it help hospitals to improve their clinical practices? Incidentally, this is the graph from Manyata.
So here in this partogram, we are actually looking at the mother as well as looking at the progress of labor. But this Manyata program is an excellent program where all the private hospitals are trained at one same level, so that all the staff are trained in the same way, so that they reach a level of competence as well. As what Dr. Mukesh also said, that the competence of the staff who is working at your hospital has to be of a good level, so that if you are doing an intermittent auscultation, then that staff should know exactly as to how it has to be monitored. So it's the fetal, the lower level staff as well as senior staff, the residents, the doctors, all are trained on the same level. And then only we can start thinking of using intermittent auscultation for low risk patients and the CTGs for high risk patients. So I think Manyata is a program which wants to bring everybody at one level, at a stage when everybody is at a good competence level. Chinmay, over to you.
Thank you, ma'am. And that's why we could. Dr. Gupta, can we take it at the end because we are running out of time? So, as we were discussing, how do we monitor the fetus? And Dr. Gupta, Dr. Meeta, would you like to tell us about the options which are available for the monitoring of the fetus?
Yeah, at the moment, we have auscultation, with a Pinance or a Doppler, making sure that the fetal heart rate is monitored. And it's already said before that 1 minute post-contraction, making sure we get an average of it. But the baby is going to talk to us through other modalities like, maybe clear fluid or straw-colored or meconium-stained fluid. In England, we routinely used to do fetal scalp blood pH. Not very easy to do in very obese patients, but we all learn how to do it. Sometimes it's a skill of medicine. Again, fetal pH should be 7.24 normal. If it's between 7.21 and 7.24, a little bit varying, but we should not let it become more acidic. Lactase estimation, again, can be done in theory. I'm not sure whether we do it we don't do it in Pune, but baseline is 4.21 and we should make sure it doesn't drop. Fetal pulse oximetry, I am not aware of it. So I think maybe Vandana is a better person to talk about fetal pulse oximetry at this stage. But what we have to do is, again, like Dr. Gupta said, take an overall view. Don't compartmentalize it. We need a safe mother and a safe baby. We need a healthy mother and a healthy baby. So at the end of the day, that's what counts. So, we can stretch it. We can stretch it to a point. We have to make sure that baby and mother should be healthy at the end of healthy and happy. Yes, Siddhesh.
Thank
Yeah, I
you.
think I would like to add about the meconium aspect also, that any meconium is not just meconium. The guideline that RCOG has come up with is like significant meconium, which is thick, black, tenacious meconium or meconium with clumps. We see people taking sections at the drop of a hat when even the meconium is slightly higher than straw colored, which is absolutely wrong. We should probably give them time, observe the CTG, take the overall picture, and only then decide whether meconium needs a section or not.
I think that's where CTG is so important, because it's reassuring to the doctor as well that though there's little meconium, baby's fine.
And
Absolutely.
Chinmay, among all of these ancillary methods, the fetal scalp stimulation has come up now. And I think we used to do it as a routine, and now it has come in the guideline that instead of doing a scalp sampling, you can do a stimulation and see the acceleration.
True.
Every
Because with scalp sampling, sometimes with meconium stained lacquer, you may get a false acidic pH, which can be avoided by scalp stimulation and seeing the physiological response of the baby. Very important.
for years.
Yes.
Yeah. Or just plucking a hair with the help of artery forceps or something on the baby's scalp.
Indian
So-
babies have a lot of hair, Chinmay. Babies are bald.
Yeah. And and in order to decide which test to offer, we would need stratification, as Dr. Gupta was saying. So, Dr. Gupta, would you like to get back to that and tell us more about it?
Okay, so when we talk about risk stratification, let me tell you an interesting story. Recently, I've been doing a course at IIM Calcutta, and we had a whole session of 3 hours only on risk stratification. And even in the business world and management world, they're talking about it. And they have borrowed this from our healthcare. So when we are talking about risk stratification, the primary motive here is to identify those who require higher attention and care versus those who require lower. And remember the 4 pillars of ethics that we are talking about in medical healthcare. One of the primary pillars, which is about, the autonomy, giving the patient the choice whether she wants to go for electronic monitoring or not, is also one of the components. Second, I would go and say the beneficence that you are wanting to do good for the patient. Non-maleficence means you want to not do bad for the patient. But the 4th pillar is for equanimity. And when we talk about equanimity, we need to appropriately allot the resources to the ones who read and require it more, rather than just glamorize and put machines on them and charge them. So this is the basic of risk stratification. Now coming to basic technical aspect of low risk and high risk strategies. So when we decide on the low risk and high risk, we have to decide which are the ones who require. When we're talking about monitoring, let's take one parameter today that we're talking about, electronic fetal monitoring. So if we want to decide who are the ones whom we want to assign as high risk, so before that, let us understand the power of low risk or even the simple intermittent monitoring. We cannot decide to let go the power of intermittent monitoring, because we have found in several studies that in long-term studies, even intermittent monitoring is not bad when you do not have, and the only impact is definitely the neonatal seizures. But if you look at long-term outcome of cerebral palsy, it does not have a major role to play. But when you do an objective assessment, there is a kind of a discipline which is created, and hence electronic fetal monitoring has become a part of our routine for most of our patients. Because if you categorize, most of them land up in that monitoring group. For example, labor aspect, the fetal aspect, and the maternal aspect. When we talk about these 3 aspects, then we talk about every patient who is induced or is given acceleration, we have to put them on monitoring. This is one of the major chunk who requires electronic fetal monitoring. Of course, besides that, the prolonged labor or regional analgesia, which is also becoming a very important aspect of our obstetric practice. Most of my patients are choosing for epidural analgesia. So hence I require that. And then we talk about the previous C-section. When we do VBAC, we need to do that. Of course, if there is any abnormal uterine activity or progress of labor is stalled, then these are the labor factors which makes us decide. But what are the factors in primary when we choose that, okay, we have to look at fetal and maternal. Anybody else wants to take it can go ahead. Probably I'm talking too much.
I think now can we go for the poll?
Sure.
So that would be good. Like, we have done this panel this way. Like, so let's take how many gynecologists are confident about the intermittent auscultation done by the junior staff and nurses. So there are 4 options. A confident, B is quite confident, C is somewhat confident, and D not confident. So can we start the poll, Mandeep?
Yes, ma'am. And while the audience is polling, Suchitra ma'am, would you like to give your inputs? Suchitra ma'am is herself who started this panel last year, and she has taken it to a height. And as ma'am rightly said, she's teachers of teachers and thousands of students. She has encouraged, made them take MRCOG like myself and be on the right clinical track. So, ma'am, as somebody who has headed all the institutions, low under-resourced institutions, developed world institutions, and Mumbai, what's your take, and which way all of us should take this further? Suchitra ma'am? Is ma'am there?
I don't see her here.
Oh. So, Archana ma'am, would you like to take that question? So, what do you think about the juniors right now, and what's your opinion about how to train them and how to be confident when they are doing what they are being told to?
I think everywhere. Is Suchitra joined back, or I think everywhere the training is a little different at the different parts of the country, and especially in the different countries. But it's very important that like first you have to have your good teachers and good textbooks, and I think Meeta is the right person because she has been involved with the training, and she's been training people for exams, and she's been associated with medical colleges. So Meeta, just why don't you take up this?
I think standardization of care, and that's what Manyata is all about. We're trying to train everybody at the same level to make sure that each of them understands their role and how important a role they are playing. That is one. Two, if you ask the junior most nurse in any antenatal clinic what is the patient's blood pressure, it is always 110/70 or 120/80. There is never a thing. So sometimes it is good, for even basic things to have basic drills to make sure that all these, it's not about form filling. It's not that the last person on the desk should be sitting and writing the forms. It is about teaching them that this is part of a team and each one of them needs to go through that to then progress on. With regards to this poll, I'm telling you, it depends on where my patient is going to deliver and who's monitoring her and at what time of the day or night when I ask for a CTG or not. I'm being very honest here. I know the RCOG guidelines, but in a practical world, making sure that you want to know that your patient is safe, and if somebody is, there at 2 o'clock in the morning saying, "Ha, fetal heart hai, madam, ha hai, kitna hai, kya hai, ek NST karo." That I know what it's going to come to, and I know the RCOG guidelines. So I'm just being fairly honest here. We are practicing in a world where somewhere that sword of litigation is always at the back of our heads. Let's be honest about it. And
I think I agree with Meeta. We all are like practicing a little bit defensive practice, which is true.
We are here to train people, give standardized care, understand the guidelines. But at the same time, I had one of my patients who told me that if you put on the CTG monitor, I can see the baby's heartbeat going up and down, and you can hear the baby's heartbeat up and down. So why are you not putting me on it? I mean, this is not. So it was a little controversial because I said you don't need it, and then I stopped myself thinking, okay, you're asking for it, and your wishes are.
Yeah, true. So do we have the polls results, Mandeep?
Sure. Yeah. All right. So majority of the audience agrees with Meeta ma'am. And yes, so thank you so much, Meeta ma'am, for those practical tips and need of standardization. This really highlights everybody's kind of fear that 63%, 64% of us feel that we are probably not confident about what we are hearing on the phone, we would rather see it on the print. So thank you. May I share the presentation again?
Yes, please. Go ahead with the, because you know, we have Chinmay, we have another only 20 minutes.
Yeah, exactly. So just moving on from here to Dr. Siddesh. So I think Dr. Gupta has already covered monitoring of the fetus at low risk.
Yes,
What is the frequency you would prefer, Dr. Siddesh?
I think every 15 minutes in the first stage of labor and every 5 minutes at the second stage of labor, and for a minimum of 1 minute after the contraction is what I would prefer to do. And not a Pinard stethoscope. I would rather use a handheld Doppler, because, or not even my stethoscope, because in today's world, I think the female has to hear that she has also heard the heartbeat. Just me telling her everything okay, for some reason today doesn't suffice that everything is okay. So I am like, ऐकलं ना तुम्ही सगळं बरोबर आहे, everything is okay. She says yes, then I am more at peace that she knows that everything is okay and we are not doing something underhand.
So I think you can skip this pregnancy thing, and we can go to the next case maybe, or.
Sure, ma'am. So, continuous electronic fetal monitoring is the need of our for high risk cases. The other poll is how many offer admission CTG. Can we save some time on this? And while audience is polling on that, Dr. Siddesh, your thoughts about admission CTG? Do you do it always?
I do an admission CTG always. This is
let's take the poll of the panelists. How many do admission CTG? Because we are not putting poll. I think we are doing admission CTG.
I also do admission CTG at all.
Yeah, I think Chinmay doesn't do so.
So yes, because the current evidence does support the use. But yes, I agree with you that
I think when you're running a small nursing home with minimal staff, I think it's better to have one baseline where you're admitting the patient. You know where you are at the start of labor. Even though it may not be a full 20-minute CTG, you know you've seen 10 minutes, everything okay, then you can probably leave it on the staff henceforth.
I think I agree with Siddesh because that's the key thing. You have to have a baseline CTG.
No, and even also if it is a medical college also, even if it is a medical college, you don't know what Dopplers have been done, whether the ones who are low risk are actually low risk or they are high risk. So even in a huge setup also, you need to have an admission CTG to rule out that the baby looks all right before she comes into labor room. Private probably yes, but in a government hospital, you don't know which ones are absent flows and they are coming in labor and IUGR and oligos. So
I was just going to say that we have a lot of transfers to their mother's place after looking for 8 months in the mother-in-law's place, and the last-minute transfers for care at parents' place for delivery, and it just says low risk, and you actually get a high risk fetus.
So I would like to add that even in a busy labor room, it's better to have in a busy labor room when you have like 4 or 5 laboring patients also. As Mukesh sir said, risk stratification, you know that out of those 4, maybe 3 are okay, you can leave them aside, concentrate on the one that is problematic, so you get a better focus even in a government hospital or in a busy labor room.
So Chinmay, I would like to throw in a word called patient centricity. So when we are talking about, you are right, Chinmay, that there is no role for admission CTG when it comes to interpretation by virtue of scientific interpretation, right? And the outcome. So when we're talking about efficacy of a particular procedure with the outcome, but here we are not talking about outcome from scientific. So what Dr. Meeta, Dr. Vandana, Dr. Siddesh said, that it is more to do with the other aspects where patient satisfaction, evaluation of, nullifying the potential inefficient reporting earlier. And last but not the least is that creating a sense of protocol when the moment this patient is admitted to get the people on board and realizing that, okay, this is the start of the process. So I think it is more to do with the other aspects rather than just pure scientific decision making. Okay, over to you, Chinmay.
So is the poll completed or we are going for interpretation? Because that's the most important thing which we really want to bring out from this panel. And we want everyone to take a very clear take-home messages. We are not teaching here exactly really, CTG, but just few key points where we are balancing out. It's a very thin balance between performing C-section and having a baby with meconium or with distress. Oh, good. We are right. Really good. This thing universally offered 51.5%.
As many as 80% of us, 81% offer frequently or universally the CTG. So yeah, almost everybody agrees.
Yes, I think this only thing is sometimes it may be a problem with the availability because I mean India is such a diverse country that where it may not be available to everyone. But if it is available, I'm sure many of us are geared up, and with these webinars and with teachings and updated information, we all know that we have to be using CTG, at least admission CTG. So, Chinmay, can we go to the next point in your presentation?
Yes, ma'am. So, because we are talking about CTGs, let us learn how to interpret it. So, there is interpretation of the features and then interpretation of the overall pattern. So, Dr. Gupta, would you like to tell us about features? How do you interpret the basic features of a CTG?
So I think, the way it was taught many times, and when I did my also course in UK, everything was like, featured around the mnemonic, Dr. C. Bravado, etc. I'm not going to get into those things for these, August audience, but I'm going to put it just in simple words that when we start off, we have to look at the baseline first. And then we're looking at the baseline. The next thing comes is the week-to-week variability. Then comes the decelerations and the accelerations and then the overall interpretation. But let's come first to a baseline. That's what you have portrayed on the screen here. So as all we know that we have to divide the CTG whether it is reassuring or non-reassuring or pathological to start with. So if there is something which is definitely a pathophysiological, then we need to take action immediately. But otherwise, what makes us feel comfortable and says, okay, this is green and we're not worried, is a baseline beat per minute of 110 to 160 and variability of 5 to 25. Now, variability has to be seen over approximately 2 minutes, where we have to extend it and we need to look at that graph for a longer time. And once we look at that for a longer time, and that is the place where we have to look for variability. Another thing, when we talk about non-reassuring pattern, when there is definitely less than 5 to 30, less than 5 weeks of variability for a long time, we need to remember that there are various factors which may reduce this variability. One of the prime factors we cannot forget is baby sleeping or analgesia. These are the commonest thing which we see reduce variability. Of course, fetal hypoxia is something we have to look at, but if it is not associated with deceleration and it is just only reduced variability, then we may have to wait. And the guidelines say you may have to wait for approximately 90 minutes and see if it is still not having any acceleration. Then we should consider that, yes, this is something which we have to look further into. So in simple words, the non-reassuring pattern does not signify a bad outcome. It is just that it requires a little more consideration and it is not an indication for C-section. If that is the take-home message we can give. Over to you, Chinmay.
Yeah, thank you, Dr. Gupta. Really nicely elaborated CTG interpretation, because the key message was like, don't write, suboptimal CTG or non-reassuring CTG. You might have to repeat the CTG. Like, if your nurse has sent you a 20-minute strip and there is no variability, I mean, they should not be ending it there. Repeat it, or maybe little longer strip should be taken. Yeah, Chinmay, what is next you want to...
Yes, ma'am. So it was about the interpretation of features and then interpretation of CTG, as Dr. Gupta nicely elaborated: normal, suspicious, pathological, and the one which needs urgent intervention. And I think pathological and urgent intervention is something which our staff really should know very well. So
Dr. Siddesh or Meeta can take it, yeah.
Yeah.
No, I just want to add a very practical point that when we are working in a few institutes and not just one institute, you need to know the velocity or the rate at which the paper graph is there. So it is at 1 centimeter per minute or more or less, because sometimes the interpretation, can become difficult. That's one. And the gestation of the age of the fetus. A smaller baby has a higher heart rate and a term baby has a lesser heart rate. That's just two things in mind, because working at 3-4 hospitals, sometimes it's been changed inadvertently to 2 centimeters a minute, and then the whole graph starts looking different. That's one. Dr. Vandana, are you taking this intervention?
So I would say that when we are taking terminologies, the terminologies have to be same all over. So it has to be normal, suspicious, and pathological. So once you have these reassuring and non-reassuring and abnormal parameters, you have to define it on the CTG and call it as normal, suspicious, pathological. If it is normal, it's a healthy baby, it is a non-acidotic baby, and you can go on with this. But if it is normal, suspicious, then it is not very bad. It is something which could be acidemic, but it may not be acidic. So there you need to do all the resuscitation, hydrate, turn her left lateral, see hypotension, look at if there is hyperstimulation, correct all those things. Those are not the ones where you will go for a section. So a suspicious CTG doesn't mean that you have to go in for a section. Suspicious means you look at the other thing, try sorting it out, and then you have a repeat CTG to be done within 15 minutes or half an hour's time. But if it is pathological, then you need to start working on it, do all the resuscitation, talk to the patient, tell her what is happening. In the meantime, you see whether it's improving or not. And if it is not, and you have a scalp stimulation also not working, then you decide for delivery. And scalp sampling, I think in India, nobody is using it so much. So you have to define them as normal, suspicious, pathological. So all practitioners and students and everybody should be using the same terminology. Then only we will not have these false positive and the clinical response to the CTG change. So the clinical response will be same for all. That's why these guidelines, and that is why it will reduce our false positive in the CTGs that come.
Siddesh, what are the CTGs where you would say it requires urgent intervention? Because that's what is very important message we want to give here. Because sometimes like even like halving and all those things, people are confused and there's a severe bradycardia and your nurse is not informing or somebody is not informing you. So just give a very clear, few points that yes, this is what is a urgent call. You have to come, doctor. Consultant has to come.
Yes. So if there is an acute bradycardia, which is a bradycardia lasting for more than 3 minutes, that is something that needs urgent intervention, and your staff has to be able to tell you that the heartbeat is dropping. That is something that is like urgent at the given moment. The guideline says 5 minutes of bradycardia or 3 minutes of bradycardia with decreased variability in the preceding CTG curve. But then if there is a deceleration for more than 3 minutes, that means there is some acute event happening. Either there is a cord prolapse, or there is an abruptio placenta, or if she is a previous cesarean in labor, she's probably ruptured, and this patient needs acute intervention at this given moment. This is like the number one cause that she has to call you. But even before that, if there is prolonged variable decelerations and you know that there is some time that you will take to get to the hospital, probably it's better to train your staff to inform you a little earlier than wait for an event like a 3-minute bradycardia. Otherwise, by the time you leave, sit in your car and get to the hospital, you probably lost the baby. So the warning sign for a staff should be something before a terminal event. That is what I feel.
I agree with you. This is the important thing. We have to take that, training the people who are primarily giving care at the site is very important. Yeah, very quickly, Dr. MG, you want to
I would say that what Siddesh said, if I want to simplify what he said and what Vandana said was that when we segregate them into three, the pathological where we have to take immediate action is one, when we see the baseline FHR tracing, which has got absent baseline FHR variability, and one of these three things.
Dr. MG, I'm sorry, I'll have to interrupt you here because, we
Can I take the physiological CTG?
Yeah. We have a little...
so we'll skip the physiological CTG as well because we wanted to elaborate really on the methodical aspects of monitoring. Physiological CTG is probably for experts like Dr. Siddesh. We'll keep another lecture on that. Limitations of CTG. Dr. Nakde, would you like to tell us?
Well, limitations is going to be subject to considerable disagreement or intra-observer disagreement sometimes. Just like your ruptured membranes and Vandana, I mean, we all have our own interpretations of this. decelerations, especially the variability. Oh, I feel it is okay. Oh, I feel so they can be a problem. Now we know that there is a strong association between certain heart rate patterns and hypoxia and acidosis, and the capacity to differentiate. My point is that there will be problems in interpretation. There will be problems in patient monitoring. There will be patient is bound to the bed or the couch. There is going to be sometimes you're not going to get a good CTG, and there may be maternal pulse by the TOCO. So you are going to have to accept the fact that the chances of an instrumental delivery or intervention by cesarean section is going to be more. But at the same time, I feel strongly that CTG is not our aim. End result of a healthy mother and healthy baby is our aim. And again, we should always have a very holistic view, not just read the CTG and react. The CTG may be poor for reasons. Okay, so advantages of CTG definitely reduces seizures. I think increases the cesarean section rate by 63%, but decreases the seizure rate, I don't know by how much percent. And I think the main advantage of CTG in modern medicine is medical legal documentation, and it's also very reassuring for the poor doctor. I mean, the obstetrician is, I think, the CTG has helped me in a few cases, because later on when there's meconium and you're rushing to theater and all, your CTG is your only backup plan. Staff changes, hospitals change, patient change. So I think that unfortunately, gone are the days when I'm the doctor, you're the patient, I say this and you agree. Now we have to justify everything what we're saying with a backup plan. And obstetrics is one scenario where I think it is all high risk for the doctor, not as much as the patient. So
I think, yep.
The change in the fetal heart reflects in the obstetrician's coronaries, I think.
I think I agree with Meeta entirely. Very, very practical points you have brought out, that we really are too much, we get counseled by CTG. It is like a counseling thing for us in case of emergency. So now, Chinmay, what are the newer modalities available for fetal monitoring apart from what the conventional CTG? So let's talk about it, and then the case which you want to bring out.
Yes.
Because we have,
Yes, ma'am. So SBS, I think everybody has spoken about. So Vandana ma'am, would you like to talk about CCTG, whether it has any role in intrapartum monitoring, and STAN?
More CCTG is only for antenatal monitoring.
Exactly.
And not for intrapartum monitoring, so it doesn't come up here. STAN is something that we use like an ECG. And I think in India, we are still not using it as much, except whatever you are going to talk about next in May. You can take it from here.
Thank you, ma'am. So yes, as ma'am rightly said, ST waveform analysis is a machine called Neoventa. It is not that easily available in India. Though it is not very expensive, it is substantially expensive, and we do not have expertise to talk about it. We are not going to talk about water birth because it is not that commonly offered here. So one important limitation of CTG, Dr. Siddesh and Dr. Gupta, is the bed-bound patient. So it is not physiological. How do we conquer that? Because we need to monitor her. We have established that CTG is the only medical legal support for us. And when we are sitting at home, it kind of relaxes our coronaries, as Dr. Siddesh said. So how do we use CTG at the same time make it more physiological for the woman?
I think telemetry is the way forward.
Great. So would you like to talk more about it?
Well, it is now what you're talking about is a wireless patch, or this is Novi, wherein the device has just stick-on attachment which is attached to the patient's abdomen, and the patient can freely move about. It is not attached to any wires, not attached to a console. The main central blue hub is the device which actually picks up the maternal and the fetal heart rate. In fact, the patient can probably even have a shower with this device on. The patient can move about with this device on. Patient can actually even attempt a water birth with this device on. So this device, advantage is that even if the patient is very obese, it even even if our regular CTG gets delocalized, this once attached does not need a relocalization also. So this is the advantage of this particular instrument that is available, and it gives us an electronic reading on a digital platform.
I think Mukesh has used it, so maybe Mukesh, you can practically talk about it.
Yeah, so basically when we are talking about this, I've been using this for some time now, and it's an interesting thing. I've used both wireless technology as well as the patch technology, and I've also used different types of patches. And what I've realized is one big advantage is it is not using the standard, the ultrasonic reading that is there. It is also monitoring the electrical activity. Second advantage here is that we are not moving the probe. Once it is stuck in a position, we are not moving with the progress of labor. So it helps to give a continued monitoring without the unnecessary intervention and keeping close watch when the patient is moving. Number 3 is that the advantage, I'm talking about the scientific advantage, then I'm talking about the patient-centric advantage. So another scientific advantage is it also gives the reading of the maternal heart rate. So one of the biggest errors and omissions that we see, which leads to problems and complications, is maternal heart rate being confused with the fetal heart rate and abnormal actions being taken. So that is also taken care of by doing this. Next is our worry about the patient being bedridden. So there is a huge amount of discussion on the risk of deep vein thrombosis and other things. And here we are not asking, especially the very obese ones. So here we are not asking her to be in the bed all the time, and we're giving her the opportunity to move around. So a walking epidural with a wireless patch which is there, and that helps, is great. These pods which are there, the blue colored pod which you can see, there are 2 pods in the system which can be easily charged, and it shows that what is the battery life, and we can easily keep exchanging it, and it's very easily exchanged. So that's a big advantage. So I'm running through the advantages, and then I'm going to tell you what are the care that we have to take. Then another advantage from the patient's perspective is that she's tired of the wire and lying down in one particular position because the wires are moving the probe, and if she moves a little, the probe moves, and everything is going haywire. One person is all the time, one relative trying to hold her, one staff trying to hold her. Everything changes with this kind of system. Now, one more thing which I have found out here is that when we are using this, the patient satisfaction is used because they feel that they've been monitored very nicely, and it's some advanced technology. Now, the downside is that you need to know how to take care of these patches. You need to know how to apply it, because if the data is not captured, it's of no use. And if the machine does show that if there is inappropriate data being transferred, it shows that which of the sites of the patch has not been appropriately applied, and that cross mark comes, so we know how to prepare it. So I'm not getting into the technical detail of how to prepare and put the patch, but one thing which I found was keeping the patch not in a very warm place. Because Mumbai is a warm place, and we'll end up the patch not working if it is kept in a very warm place. So you have to keep it cool, and that is one of the things which I learned in a hard way, where all the patches got dysfunctional, and then I had to go all over again. So I think these are the features which we need to understand, that here the advantage is there. And let me tell you, I also experimented with asking the woman to go in the shower and keep a watch on the machine whether it works. It does. So it was an interesting experiment which I did with my patient. Right? Over to you, Chinmay.
Yes, sir. And yes, we commonly ask them to shower. One of the best ways of pain relief, we avoid epidurals. And from the introduction of these patches, my rates of epidurals from 50% have dropped down to 30% now. So we are happy about it. So moving on to this interesting case, and I think with ma'am's permission, we'll conclude at this level. So here is a 35 years old, previous 7 pregnancies, 6 losses, no living issues. Came with the 7th pregnancy, and she GDM on metformin, antiphospholipid syndrome on ecosprin and LMWH, and she has a high BMI. She is now 38 weeks pregnant. So, Dr. Siddesh, what would you like to do with her? How would you like to deliver her?
She's BMI is high, but then she has delivered once vaginally in the past. We have written para 1 death 1, so I assume she has had a previous vaginal delivery in the past. So pelvis is not a question. Only thing is she is currently on enoxaparin and ecosprin. I would probably even offer induction of labor at around 39 weeks of gestation, and consider delivering her vaginally.
And that is what was done. So we asked about her obstetric wishes, and she wanted 2 more babies at least at that stage. And how would you like to monitor, Dr. Meeta?
I think the new device, which I have not used, seems very appropriate for her. But in the current scenario, continuous CTG is what I would opt for, because I would want to make sure that this baby and the mother is healthy. First, monitoring the mother as well, making sure she's a diabetic lady, so her sugars, making sure she's not, she's comfortable, adequate pain relief, adequate hydration, and for the baby, of course, making sure that the haptogram is maintained. If I need to augment labor at any stage, I would. She's been on ecosprin and low molecular weight heparin to make sure that she's, doesn't get any bleeds, small bleeds, and progress making sure she delivers. But I would not blink if anything went wrong and took her for a cesarean. I must say, I am not that brave.
Absolutely. Nobody should be.
Ready with the theta stuff and induction, but I will be ready.
Yeah.
And perfect.
Yeah. Thank you so much, ma'am. And Vandana ma'am, do you think fetal scalp electrode would help in this place? And how many units in India do you think would be using it?
I think fetal scalp electrode is not being used by anybody in India, probably maybe Hyderabad. But then for such a patient, the patient will not allow us to put that electrode also. It is both ways. You need to manage her, you need to give her a good baby, but you will not want anybody to touch the scalp of the baby at all, even for putting in an electrode. So I think here your device is going to work the best, and it needs a monitoring because it's a bad history. She is diabetic, she is on heparin, it's a very precious pregnancy. So definitely your device is going to work well for her.
Thank you, ma'am. It did indeed work well, and this was the CTG throughout. Baby was very, very cooperative. We were vigilant, as Meeta ma'am had said, and we probably would have sectioned at the top of her hat with that history. So she had her first delivery and the second delivery just during COVID times. You can see the cloth mask around him over there. So yeah, so that is how it is.
You have been very brave, Chinmay, with these women who had previous losses and phytobies. I think really good. Your device has really worked well here. So I think this is the message probably I wanted to give here, that not necessarily that you have to do section even if there's a bad obstetric history. When every pregnancy is precious, every single baby is precious. So you just have to, overall, as Meeta and all panelists have been saying, there has to be a holistic approach to the care of the men. And as Dr. Mahesh also said, autonomy, the women should be choosing, like whether she should be immediately offered a C-section because of her bad obstetric history, or if she has, you should ask her reproductive, choices to the women. That's very, very important. So, is there? Shall we take a third poll, or just take all the panelists? Just one take-home message on intrapartum monitoring. So we begin with Dr. Vandana. What message you would like to give to the attendees regarding intrapartum monitoring?
A small line: don't treat the machine, treat the patient.
Very good. What about you, Meeta?
I think the aim of monitoring is to identify situations that precede hypoxia. Don't wait till it's too late.
Very good. I think that's you should be in the life in the middle, not in the extremes. Yeah, Dr. Iyer. One take-home message from your side.
You're muted.
I think keen observation in your CTG. Don't miss any finding, and make sure that everything is in best intention for the patient and not just for the sake of doing a particular procedure. Patient has to be focused.
We welcome Professor Campos here on this platform. And Dr. Chanchal is not here. Dr. Gupta.
I would quickly say one thing, that we need to combine the three powers that we have. If we use the technology and the development of science in the form of the machines that we have and the AI that we are getting now, along with our emotional intelligence and the IQ we carry, we'll be able to give the best to our patients.
Thank you, Dr. Gupta. I think it was a wonderful panel I mean, most of the points were brought out beautifully. We have practical points, and we had most modern, like machineries which we can use. We have talked about manyata as well, like how in India we have been practicing, and in the private practice setups, we are trying to bring everybody on the same page so that everybody is talking the same language when we are discussing about the CTG, or even I'm telling Vandana that this is reactive, means she knows that what I'm talking. So that's what is the message we want to give from this platform. But we have to use technology. It is available. We have to use it judiciously, and it is for the best interest of the mother and the baby. And documentation is very, very important. So Chinmay, some from you, and then we can just wind up the panel. And we thank you all the panelists. So over to you, Chinmay.
Thank you, ma'am. And our stalwarts are back. We were missing them dearly. So Dr. Pandit and Dr. Bhalera were here. So, ma'am, would you like to give us some concluding messages with your enormous experience and background in all these setups, public as well as private?
Unmute yourself, Suchi.
Ma'am, you're on the mute.
Thank you for having me there as the chairperson. And I have listened to 3-4 of the cases. In between, I had to just go off. But I think interesting points which have been brought out, and I think it's very, very important that we have technology work for us. We should be running after technology. And I'm sure with the new device, that's a much more better alternative to using a fetal scalp electrode, because we used to use that in UK, but even in the UK, I used to find it very cumbersome. And somehow the thought of putting it on baby's scalp never appealed to me. So this device is definitely going to be a fresh sort of an eye-opener. And I'm glad that you and Dr. Archana Basair have actually got together all these cases, and I've given some tips to the audience, because eventually, when you're following any kind of a guideline, be it for a CTG, be it for HDP or for anything, the good clinical practice guidelines are derived on the basis of, expert observations, research, as well as what is, applicable to that particular country. So if we have something like that, even for us, we have it for many, many years. We've been doing it since 2013. All the presidents have been taking up good clinical practice guidelines. And when they're there, at least for the gynecologists, the working gynecologists, it's like a yardstick. It doesn't mean that it's like a protocol. But I'm very glad that you've also brought Professor Pomos to talk about the guidelines. So I think these are very important tips which you brought out. And GE has been great, in coordinating everything together. I remember last year also we had a wonderful panel on CTG. And I hope that more and more people resort to using CTG and use it intelligently, and not use it just for a pretext for increasing the C-section rate. We understand Robson's criteria is there. We know how to justify our C-sections. But at the same time, as Mukesh very rightly pointed out, intelligent use of your brain, your knowledge, your experience, and the technology will help us to have a better impact, because at the end of the day, we want a happy mother and a happy child. No one wants to face, problems which can happen to the baby because probably you have defaulted. So I think your device is also going to go a great long way. And once again, thank you, Archana, and thank you, Chinmay, for having me over. And thanks to all the brilliant panelists. Thank you very much.
Suchitra, you have to stay. You will be introducing our speaker.
Yes. I will.
Yeah.
Yes.
So thank you all the panelists. It was a wonderful having you all, and thank you for sparing your time and your experience, and really practical and take-home points. So thank you, Chinmay. And I think we move on to the next thing. That's everyone is eager to listen to the talk by Professor Campos.
So, may I request G to introduce Dr. Anshu, who will be introducing the further team.
Yes, Dr. Chinmay. So it is a wonderful session going on. In the mid of it, I would like to introduce Dr. Anshu Basair. She is a junior resident, Department of Obstetrics and Gynecology, MGM Medical College and Hospital in Navi Mumbai. She has published papers in national and international journals. She has co-authored the book called Ultrasound for Beginners. She has also co-authored chapters in FOGSI publication and awarded in presentations on MOGS 2020, awarded first prize in the quiz for genetics at INHS Ashwini. She is an interactive member of FOGSI Young Talent Committee, and her areas of interest include ultrasound and endoscopy. Thank you. Dr. Anshu.
One second, there appears to be a bit of a problem.
While Dr. Anshu opens the CV.
Sorry. Yeah.
For CV of Dr. Suchitra. So I think they will be putting CV.
Yeah. Thank you so much for that introduction. I'm really thankful for this opportunity, and it gives me great pleasure to introduce the next speakers. Can I please have the CV here?
Chitra and Dr. Sarita CV you have to complete.
So first of all, I would like to introduce Dr. Suchitra Pandit. Well, she really does not need any introduction. She's a consultant in the Department of Obstetrics and Gynecology at Surya Hospital, and she's a chairperson of AICC RCOG. She was there in 2017 to 21. She has done tremendous work in obstetrics and gynecology. I have personally attended many of her lectures, and she has been president FOXI and ICOG. She was chair of SAFOG. I mean, I could just go on and on. So we are very thankful and happy to have her here with us. And next, next I would like to introduce
CV, please. Dr. Sarita CV.
Next, I would like to introduce Dr. Sarita Bharirao. She's president of MOGS, chairperson EICC RCOG West Zone. Also, again, someone who does not need any introduction. Is my quiz committee chairperson of FOXI. Currently working in Breach Candy Reliance at HNS in Saifi Bhatia Hospital, and she's immediate past president AMWI. So we're very happy to have her here with us as well.
Over to you, Dr. Suchitra, for introducing our speaker for today, Dr. Suchitra.
Lovely to see you, Anshu, and thank you for all the kind words. So can I have the screen share for Professor Campos's CV, please?
I think meanwhile, when they are loading the CV of Professor Campus, Dr. Suchitra, it will. You can just tell us about some guidelines and things which you were
responsible. Yeah. So in 2014, I think one of the very important guidelines which I was very, very passionate about is the HDP, that is hypertensive diseases in pregnancy. And just to tell you that guidelines is not an easy job. It took us nearly 6 months to prepare that one guideline. We had nearly 40 experts and a core group wherein we looked through all the possible literature that was available, and we went in through nearly 15 meetings and finally formulated the guideline. And once that was done, we had to present it to all our experts. They gave us the recommendations, and then we edited that. And I'm happy to say that those guidelines, majority of the Foxians have been following that, and we were very important that we must know how to prevent eclampsia, and at the same time, we must know that the predictors for preeclampsia are few. And in the recent updated guideline, we talked about the gestosis score also. So we are happy. We talked about the low dose aspirin as well as what constitutes the high risk and how we can get that down. Because we know that PPH is the number one cause of maternal morbidity and mortality, and HDP ranks second. So I think once we were done with that, we were really very relieved because it was an immense work in 2014 to do it. The second time, remember friends, every guideline after 3 years gets revised with the newer data added on. And after 3 years, we revised it again, and Dr. Nandita's here. And that guideline now is very much available on the Foxy websites. And through the organization Gestosis too, we have it released at most of the workshops and conferences and webinars. We're talking about it.